We'll move on now to our final speaker, Dr. Leca.
Thank you, Matt. Let's see. Can you see my screen?
Yes, looks good.
All right. Well, Matt, thank you so much for the invitation to present at Renal Grand Rounds and live from Seattle this Friday morning. I'm very excited to present on this subject because there have been remarkable new developments in biomarker monitoring that, in my opinion, have reignited the innovation in kidney transplantation and are paving the way for individualizing immunosuppressive approaches. My focus today will be to outline some of these concepts and emerging developments in allograft immune monitoring. I have the responsibility of serving as a principal investigator on multiple investigator-initiated and industry-sponsored trials. I look at this as a duty as well as a requirement to allow our patients first-hand exposure with the developments in newer immunosuppressive agents and technologies, as well as keeping our team competitive at the forefront of these developments. I will be concentrating my presentation on the immune status of the allograft versus other clinical areas monitoring. I plan to review concepts that may guide in rationalizing monitoring modalities. We'll outline the shortcomings of the current status quo of clinical observation, and then we'll review some of the exciting and new emerging biomarkers and their potential for refining our transplant care and hopefully improve the long-term outcomes in kidney transplantation. I'll start with the clinical case. 49-year-old woman with a history of severe hypertension, end-stage renal disease, dialysis for 4 years, not sensitized, receives deceased donor renal transplant, estimated post-transplant survival at 25%, well matched with the kidney donor profile index at 23%. Receives thymoglobulin induction and triple treatment with tacrolimus, myfortic, and prednisone. The problem post-transplantation was development of diabetes requiring insulin. The 3-month visit, she feels great. Blood pressure is well controlled with the use of an angiotensin receptor blocker. Creatinine is 1.07, the best it's been so far. The same for proteinuria, which has been gradually improving to low values. Urine analysis was completely negative. BK screening test in the urine was negative. CBC, complete metabolic panel, were normal, and donor-specific antibodies, which we do routinely at 3 months, were negative. However, this new test that we have instituted as a screening, the cell-free donor-derived DNA, came back with an elevated value of 2.7%. So intuitively, this is how we clinically visualize the progression of allograft injury, from a transcriptomic alteration phase in which certain genes start indicating allograft damage to a morphological alteration phase, which is subclinical but histologically showing injury, and then progressing longitudinally further to clinical alteration, which for us means elevated creatinine or proteinuria, and ultimately kidney failure. Quite unlikely this is a uniform linear progress, as there are multiple pathways: inflammatory, injury, and fibrotic. Likely these are intertwined, and also reversal of the course of injury is possible under certain therapeutic conditions. Think about this case. The cell-free DNA was elevated, which suggests the possibility of ongoing allograft injury, possibly in the morphological alteration phase. It only remains to be seen if the histology concurs. So stay put for now. So most of our established modalities of monitoring operate in that clinical alteration phase. As such, we use renal function monitoring and proteinuria as markers of injury. That is usually a late phenomenon, and truly without ability to differentiate between causes of injury like rejection, infection, obstruction, medication toxicity, recurrent disease, and others. Creatinine is our multi-use tool, but somehow behaves more like a multi-use hammer if you only rely on the creatinine for differential diagnosis of dysfunction. We use medication levels to ensure adequacy of the immunosuppression, but truly those are based on a one-hat-fits-all type of paradigm, with very loose differentiation on population level characteristics like sensitization, or based on previous events like infection or rejection without a proactive individualized approach. Viral monitoring is used mainly from an infection prevention perspective, but can provide loose insights in regards to the level of immune responses. I like to refer to the BK virus as a domesticated virus, which we use frequently as a gauge to over immunosuppression. We use anti-HLA antibodies pre-transplant as part of the cross matches as predictors of rejection risk, or post-transplant, where the de novo donor-specific antibodies are markers of under immunosuppression and rejection. Non-HLA antibodies have also been predicated to be responsible for rejection with an increasing interest in their study. In the interest of time, I will not be talking about non-HLA antibodies today. Beyond everything else, kidney biopsy remains the gold standard for rejection and evaluation of the health of the allograft. This is the only non-immunology monitoring that we'll be presenting. Tacrolimus level monitoring is an integrated part of clinical care of transplant recipients. In newer data suggests that level variability predicts rejection is associated with fibrosis, development of DSAs, and allograft failure. Less recognized and surprisingly rarely mentioned is the variation of the free fraction of tacrolimus, which, as for any other drug, is responsible for the effects and the side effects of the drug. Tacrolimus is measured in the whole blood as it is distributed both intra and extracellularly. In this example, the free fraction of whole blood of tacrolimus of 7 will be markedly different from patient 1, which has a normal chemistry profile, to patient 2 that has a more ill profile with a lower albumin and lower hematocrit level. This concept was first demonstrated in pregnant women with the expansion of their plasma volume by Mary Herbert and Tom Easterling at the University of Washington. And I'm sure you probably noticed this in your practice as well. For example, with the higher level of tacrolimus toxicity that we observe in the liver recipients versus the kidney transplant ones. With the newer and more sensitive techniques, we may be able to test the free fraction directly in the future, which may allow us to better individualize immunosuppression. Donor-specific antibody monitoring is commonly employed post-transplantation for risk stratification and surveillance of rejection. Our transplant center uses this schedule of 3, 6, 12 months, and then we test for with all the anniversary visits. The DSA testing is not always standardized between laboratories, but most use a Luminex platform using single antigen beads. You'll read frequently that the survival benefit of surveillance is not proven. However, the detection of DSAs is strongly correlated with the outcomes. This is a study from France that shows that patients that developed DSAs but had no significant chronic injury on their biopsy had actually similar outcomes to those that had no DSAs but had severe interstitial fibrosis and tuberous atrophy. So I think it is likely that the lack of surveillance benefit reflects the absence of effective treatment for the injury associated with the DSAs, most of all. A substantial shift in defining the antigenic load of a mismatch is underway from the current dry nomenclature-based that fails to define the immunogenicity of a mismatch to a more functional epitope or epitope mismatching. Anti-HLA antibodies form against specific epitopes that are not present on self-antigens. In turn, each functional epitope is recognized by a number of antibodies, which explain why we can see sensitization across a broad range of nomenclature different HLA antigens. The term eplet has been used to describe these polymorphic residues, which act as a functional epitope. In this paper by Peter Nickerson, class 2 epitope mismatching, particularly for DQ eplets, was shown to be associated with a higher risk of de novo DSA, rejection, and graft failure. Future understanding of eplet mismatching may allow individualizing the rejection risk and better guide monitoring modalities. We do require kidney biopsies for a diagnosis, and the diagnostic classification are intended for prognostic insight. However, histological lesions may be identical despite different etiologies. See glomerular disorders for those that are not working in transplant. Interstitial inflammation is a great example, and debate regarding the meaning of early injury in borderline acute cellular rejection with or without tubulitis persists. Microvascular inflammation is another example, strongly anchored in the antibody mediated rejection classification, but may also be present in T-cell mediated rejection as well. Furthermore, biopsy suffers from variability in sampling, as well as pathologist subjective interpretation. It is invasive, unpleasant, costly, and is associated with severe complications, rarely, but everyone that has performed enough of those knows exactly what I'm talking about. So let's go back to our clinical case. Our biopsy was performed because it is our gold standard for diagnosis, not only for rejection, but for a long list of differential diagnoses that can be settled easier many times by shoot first and ask questions later. We can detect subclinical injury, as in this case, which was prompted by a novel biomarker, but we can potentially, by chance, detect injury if we are to perform a surveillance biopsy. However, in these early cases, biopsies may suffer from the vague classification of injury and superimposable injury elements against diagnostic criteria. This is the actual biopsy from the case I presented that shows a very well preserved kidney tissue with limited chronic injury, but with the presence of microvascular inflammation, which is defined by the presence of glomerulitis, as you can see in the right, and peritubular capillaritis, as you can see on the left image. So what is the diagnosis? Our pathologists didn't call it anything. They just described the lesions because in the absence of DSAs, only 2 of the 3 criteria for antibody-mediated rejection were present. This example outlines the possible imprecision of the current rejection classification, which in turn may affect novel test validation based on an imperfect gold standard. I've borrowed this perspective slide from John Friedewald's previous presentation, as I think it greatly outlines another intuitive process of injury progression and the rationale for immune monitoring. Immune activation and inflammation can occur after transplantation and may or may not cause a clinically significant decrease in GFR, which may prompt a biopsy. A surveillance biopsy, on the other hand, has the potential to capture this subclinical injury, but the timing may not necessarily align with the inflammation peaks. And I would argue or add that may not even be recognized by the histological classification as such. It is hypothesized, based on the data going back to the surveillance biopsy cohorts reported by Nicolae, that this inflammation, either subclinical or clinical, contributes to cumulative chronic injury and fibrosis. But I think it's worth mentioning as well that there is no data yet to show that intervening against this early inflammation prevents the progression of chronicity. This is the way I visualize the current immunosuppressive interventions and opportunities for monitoring. I think we do reasonably well for the vast majority of patients, reflected by the overall low risk of rejection, low infection risk, and overall great outcomes, short-term outcomes of kidney transplantation. To the left of this naturally distributed curve, there will be patients overexposed to immunosuppression. We identify those because they have repeated opportunistic infections, they have bone marrow suppression, they have maybe more severe viral reactivation. We reflect on their immunosuppressive level exposure. I think we should continue to aim for developing a proactive biomarkers to identify these patients before a clinically obvious complication occurs, where at the minimum, we can use the current techniques to ensure quiescence as we gradually reduce immunosuppression when indicated. To the right of the curve illustrates where most of the recent progress of biomarker development has occurred. Being able to identify those at risk for rejection or already subclinical rejection has been the focus of cell-free DNA, gene expression profiling, urinary biomarkers, and in part only DSA monitoring as more reflective of an established, already late injury in a way. The horse is out of the barn already, as previously discussed. It is important to note that a patient immunological profile on this curve may change over time, either by changing the intensity of the immunosuppressive regime or through a change in clinical condition or comorbid load. Patients may get sicker or healthier. There are many potential uses of biomarkers, but the current development has been mainly focused on injury and rejection risk assessment. They have the potential of guiding immunosuppressive changes. Their aim is to prevent a biopsy by ensuring immune quiescence or allow a diagnosis of graft injury that may be better guiding the timing of a biopsy, as in the clinical case that we discussed. The potential for surrogate endpoints in clinical trials may allow medication development, potentially addressing this long-term graft survival issue that we have in transplantation. This is a very loose outline of the current and emerging modalities for allograft monitoring beyond the renal function, arranged in order of their invasiveness. Due to time limitations, I will be focusing only on the emerging and newer developments with urinary biomarkers, gene expression profiling, and cell-free DNA. Microarray-based molecular diagnostic system, MMDX for short, was developed and ongoingly validated by Phil Halloran and collaborators. It isolates mRNA from allograft biopsies and measures genome-wide gene expression using microarrays. Machine learning algorithms then translate these gene expression measurements into diagnostic probabilities using an archetypal analysis in relation to rejection within 6 diagnostic categories, as seen in this report. It has the potential of refining histological diagnosis and comparison with the reference set of cases with similar gene expression characteristics may and can provide a proxy for prognostic information as well. Dr. Sutantiran and colleagues analyzed data from CTAT-04 in 485 kidney transplant recipients and identified a group of 3 gene signatures that can predict rejection using urinary assays. As seen in the associated figure, the diagnostic signature starts separating at 120 days and predict rejection, but with a very clear separation 3 weeks prior to the diagnostic biopsy. This assay is not yet clinically available, and further validation studies are required and are ongoing. Q-score was developed by Dr. Sarwal and colleagues, and it is a composite biomarker score based on 6 urinary biomarkers, including cell-free DNA. At a cutoff of 32 out of a 100 scale, it appears to detect rejection, either cellular or antibody-mediated rejection, as in this graph, and it does that irrespective of kidney function impairment, as in the case of clinical or subclinical rejection. Further validation studies are needed and underway. Donor-derived cell-free DNA is truly the most clinically used emerging biomarker with the largest and fastest growing publication data as well. It is based on detecting fragments of genomic DNA released after cellular injury. Those are degraded in nucleosomal units of approximately 160 base pairs that are then naturally cleared by the liver and the kidneys with a half-life of approximately 30 minutes. The methods used for measurement of cell-free DNA vary, but most of the currently available methods, assays, use next-generation sequencing against the panel of SNPs, and then mathematically being able to differentiate between the DNA origin differences and express the donor-derived fraction of the cell-free DNA. This is data from the seminal DART study that showed the ability of donor-derived cell-free DNA to differentiate active rejection. Median values were 5-fold higher in patients with rejection versus non-rejection. Below, you can observe the serum creatinine levels being equivalent between rejection and non-rejection groups, with a c-statistic that was not different to a coin toss. It is increasingly observed that cell-free DNA performs especially well for detection of antibody-mediated rejection. Again, this is data from DART study that shows a much higher cell-free DNA values with antibody-mediated rejection with a c-statistic of 0.87 at 1% threshold. Also notable, the very high negative predictive value of 96%. The main hypothesis for this observation lies with the implied endothelial injury with antibody-mediated rejection and proximity to circulation versus the T-cell mediated rejection, which at least in the early phases will be more confined to the tubular interstitial compartment. An additional hypothesis refers to the antigenicity of DNA molecules themselves, able to trigger innate and adaptive immune responses and possibly antibody-mediated rejection. This data from our site, recent publication, looking at a cohort of patients with unsuspecting clinical characteristics. As you can see, as a matter of fact, numerically, the eGFR was higher in those with high cell-free DNA versus those with low cell-free DNA. There's no difference in proteinuria. We found a very strong association between cell-free DNA and DSA in this cohort, and also we're the first one to report an association with the individual characteristics of antibody-mediated rejection, gradual association with C4D, glomerulitis, and peritubular capillaritis. Evolving applications of donor-derived cell-free DNA suggest that the more sensitive cutoff may be required for T-cell mediated rejection. This is a study by Stites, in which patients with low level of rejection, either borderline or 1A, demonstrated worse decline in GFR, a high risk of DSA formation or recurrent rejection at 6 months from the initial biopsy if they were exhibiting a cell-free DNA value above 0.5%. The violin plot to the right illustrates that maybe a more continuous approach may be better, maybe it's better said actually a more disease individualized approach for using the cell-free DNA as a biomarker. Peripheral gene expression profiling has been increasingly proposed as a monitoring modality for the health of the allograft. In this study by Friedewald and collaborators, they have analyzed the data from CTAT-08, which was designed to detect and study the treatment effect in subclinical rejection. Investigators identified 57 gene sets that was differentially expressed and was able to distinguish subclinical rejection from patients with no rejection with a very high negative predictive value, practically able to identify patients with no rejection with very high accuracy. Newer data combining gene expression profiling with donor-derived cell-free DNA measurements increase the diagnostic precision, as illustrated in this Venn diagram, with the gene expression profiling more likely to detect the T-cell mediated rejection and cell-free DNA more sensitive for the antibody-mediated rejection. Additional gene expression profiling tests have been derived from the study of genomics of chronic allograft rejection, VOCAR, a legacy of Dr. Barbara Murphy's research. These tests are based on whole blood RNA sequencing and identified a 23 gene sets that may predict risk of rejection and allograft survival pre-transplantation. Now, the 17 gene signature set was shown to be associated with rejection at 3-month biopsies, DSA formation, and graft survival. We're currently participating in the clinical validation of this test. iBOX is a prediction model for the risk of allograft loss that has distilled multiple donor, transplant, and recipient categories factors into a set of 8 parameters: 4 clinical, which is the vintage of transplantation, EGFR, proteinuria, and presence of HLA antibodies, and 4 histological scores: interstitial fibrosis, tubular atrophy, inflammation scores, microvascular inflammation, and presence of transplant glomerulopathy. This model has been developed by Dr. Lupi and collaborators using data from Europe and North America, and it was further validated on multiple other databases. As with any other model, it is dependent on the quality and accuracy of the data that goes into it, and its reliance on histology is an important aspect, although there is some validity of using the iBOX derived only from clinical parameters, in which case it becomes strongly reliant on EGFR. These are some examples of clinical applications of iBOX. To the left exemplifies a patient change in its 7-year graft loss probability greatly affected by successful treatment for rejection, as in this example, decreasing from a likelihood of 95% to 50%. It is arguable that this data is less important on a day-to-day clinical care of an individual patient due to the high reliance on GFR as well as the implied default interventions in the case of graft dysfunction. We will treat that rejection, we will do whatever we can for an elevated creatinine anyway. The value of the iBOX truly shine as a population level predictor, with its potential for being a surrogate biomarker for long-term graft survival, essentially needed for any new medication approaches that want to tackle that. The graph to the right shows this concept in action, applied to the 1-year data from a multi-center trial comparing 2 immunosuppressive protocols based on everolimus plus low-dose tacrolimus compared with standard tacrolimus mycophenolic acid regime. And then it showed the projection of the survival curves all the way to 11 years post-transplantation, demonstrating non-inferiority between the 2 arms. Further validation in different populations of truly the embracing of the iBOX as a clinical trial endpoint is needed. So let's take a step back as we briefly review some of these evolving monitoring modalities and reflect on their potential for use and disadvantages. MMDX may improve the diagnostic classification and provide diagnostic and prognostic information. Urinary biomarkers have been shown to correlate and predict rejection. Blood gene profiling have the potential to detect allograft injury in the transcriptomic alteration phase, guide early interventions, detect subclinical rejection as well, or just provide reassurance with a high level of negative prediction. Not intended last, as probably the most established clinical biomarker, cell-free DNA also has a very high negative predictive value for rejection. It is particularly sensitive for antibody-mediated rejection. For all these biomarkers, their outcome benefit needs to be established, and truly their cost needs to be adjusted to the value that's provided by this test. I particularly like this epidemiology concept slide. As clinicians caring for a patient in front of us, we are most interested in the performance of a test from its positive and negative prediction. In other words, is the result meaning that my patient has rejection or not? It is important to recognize that negative and positive predictive values are dependent on the prevalence of the disease as well. And rejection has a low prevalence of in transplantation at 10% or even lower. This implies that rejection biomarkers are going to be poised to aspire to a very high or to a high negative predictive value as seen in the examples that I've given so far. There are inherent issues with biomarker development. Large validation studies are required, but the transplant population is small and heterogeneous, and our gold standard is imperfect. That said, most of the biomarkers are recruiting in registry trials that are aimed at validating patient utility in the real world. There are many questions that need refining. At what testing time points, what is the most adequate frequency of the testing, and what are the most accurate thresholds for interventions? In summary, transplantation is a complex field, and there's probably never going to be a single modality of monitoring that will be sufficient. It is, however, a very exciting time in seeing these new monitoring techniques, and we welcome the opportunity to experience in them for the benefit of our patients by allowing a very substantial step forward towards the goal of individualizing medicine. More work is needed, defining the best applications for these biomarkers in terms of risk, monitoring, prediction, and future validation studies are needed, both at the population as well as at the individual care level. I don't think there are any worries for our pathologists either. Biopsy continues to play an essential role, but the newer techniques may add prognostic as well as diagnostic value, may help refine the rejection classification, particularly in the early injury phase. I want to end by acknowledging my research team, Nidhi and Belinda, the administrative team, grant support from Tyler and Marisa, as well as my colleagues from Transplant Nephrology team. Thank you so much.
Thank you so much, Dr. Leca. While people are formulating questions, there's one from Ian in the chat. So, more clinical chemistry, should we aim for lower whole blood tacro levels in patients with hypoalbuminemia and anemia?
Yes, very likely. Yeah, unfortunately, we don't have a way of monitoring the free fraction yet, but data that it's been shown in pregnancy, as well as the clinical observations, truly suggest that patients with lower levels of albumin and anemia, they will very likely have a higher free fraction of tacrolimus.
Other questions for Dr. Leca? Nicolae, which of these, besides the AlloSure, obviously, which is now really being used clinically here, which do you think is the next most likely to make an appearance in terms of routine clinical use here?
Well, we already use cell-free DNA, so we use actually 3 panels of cell-free DNA. AlloSure is one of them. Prospera is the Natera product, and then TRAC is the transplant genomics one. They all kind of do the same thing. I think they have slightly different sensitivity and values that are representing thresholds for rejection or suspicion for rejection. Definitely, I think the cell-free DNA has made a huge impact in terms of detection of subclinical injury. I think we can do better than that in the future. I think the gene expression profiling has truly the potential of getting us to a much earlier phase. I think in an ideal world, we should be able to detect a gene profile change and potentially just make a slight change in immunosuppression up or down, rather than reacting to an injury that's already present. I think that would be an ideal situation in transplant. I like urine as well as nephrologist. I think that's where the truth is many times, and having validation in terms of urinary markers, I think would be fantastic. Urine is easy and non-invasive, and we're great to see those. We have the least experience with the urinary biomarkers yet. We are in the final stages of establishing a new registry using the QSUNT score, and we'll see how that goes. But yes, for sure, the cell-free DNA modalities are the most established at this point.
All right. Well, thanks so much, Dr. Leca.